Allergies Syndrome. Super excited to be here for this event. 9th International Symposium on Allergies Syndrome. We were supposed to be in Cincinnati for this event, and we made a decision in January, like so many, to make this virtual. And so I'd like to thank Jeff and Eden Lord for working with us on this amazing platform. So thank you so much, Jeff and Eden. This My City Med platform is new for us, and we hope that it's easy for everyone to navigate. If you have any problems at all, there's a help desk. If you go into the lobby, you'll see at the very bottom, there's a little help desk icon. They are monitoring that and will answer any questions that you have. I'd like to really take a moment to thank our partners for allowing us this opportunity to, first of all, work with Jeff and Eden Lord and just allow us this opportunity to have this wonderful event online. Of course, we always want it to be in person, but we can't help that right now. So we're gonna make the best of it, and we hope everyone enjoys this. Our presenting sponsor is Albareo and also Mirum Pharmaceuticals. Our event sponsor, Travere Therapeutics. We have our Alpine sponsors, Mayan Technologies, Children's Hospital Philadelphia, Cincinnati Children's. We also have Stanford Children's Health, Lucille Packard, Cincinnati DHC, Cords Registry with Sanford Research. Also our media partners of Patient Worthy and RD360. Thank you so much for supporting this event and our organization. First of all, I want to welcome everybody again to this 9th International Symposium on Allergies Syndrome. We have families from all over the world. I can say right now off the top of my head, we have families from Australia, Kenya, Peru, Bolivia, Argentina, Colombia, Netherlands, New Zealand, Poland, Canada. It's an amazing event. I'm super excited. Egypt, we have some folks from Egypt here that will be talking later. Super excited to hear that. It's an outstanding lineup of speakers, families, and our partners. Please take every opportunity you have to reach out to them, talk to them. You can click on them to chat. You can go into the expo hall and click on their booths in there and chat with them there. We want you to explore this platform and get everything out of it that you possibly can. I'd like to start really by saying the first symposium that I ever went to was in 2014. At the time, my children were about 11 years old, and it was the first time I had ever met anyone in person. It was so memorable for me, and I think there's nothing like being able to hug someone that you've talked to for years online, to have that personal connection, have your children, playing with the other children, identifying and relating to the parents that have been through similar situations that you have. So we're trying to recreate as best we can this personal connection. There are lounges here that you can go to and chat. Please feel free to use those. There's a Spanish lounge, a children's lounge, and an ALGS adults lounge there. Still try to make connections and get to know people here. I'd also like to thank Cher. Cher is the executive director of the Allergies Syndrome. I'm telling you, this would not be done without her. She has spent countless hours on this, and I want to really share, man, thank you so much. This is unbelievable.
Thanks. You know what? The thanks goes to Jeff Lord for stepping me through every single piece of this. And I can't tell you how many times I sent him a final agenda, and he was always willing to just keep on updating all the way through about an hour ago. So there you go.
A final,
I'm so
final,
excited to
final,
see
final.
everyone. Yeah, my final. I'm so excited to see everyone and looking forward to a great 2 days.
I'd also like to thank Ida and Alvaro Leal. Alvaro, where'd you go? So, oh, he's in the background there in Ida's screen. Give a wave, Ida. Ida and Alvaro live in Miami, and they're going to be leading the 3 Spanish-speaking sessions that are going to kind of run simultaneously with our agenda. And so at any time, you can hop in and out of one or the other if you want to see it. I do have a few housekeeping things before we move on to Dr. Bacoli, but Ida and Alvaro, thank you so much for dedicating this day, dedicating your time to the Spanish-speaking families. We have a wonderful group coming in for that, and we could not have done it without you. Thank you.
It's our pleasure, Roberta. Thanks to you and thanks to the community.
So housekeeping, like I said, you could come in and out of this at any time at your leisure. Please know that 10 minutes before the session ends, the time of the session, no one will be able to come back in. So if you go out, you won't be able to come back in, but you'll be able to move into the next session. I would advise, and I think everyone, if you can, go back into the lobby at some point and find the conference agenda and print that so you can kind of have it readily accessible so you see what times each thing starts and when they would end. And that way, you know, if you go out, you can't come back in. The lounges, again, great place to go. They're open all the time. There are materials in there. You can chat in there, get to know some people in there. They're really great. We also, the help desk again, at the very bottom of the screen, not here, but back in the lobby, you'll see a whole menu. You have the help desk, you can get to the auditorium, everything from there. Those of us are wearing red t-shirts. These are people that are either on our board or Ida and Alvaro, or I think some speakers might have red as well, but you can ask any of us anything. I see right here, Chris Halloran is on our board. Thank you for being here, Chris. You can ask him any questions at all. Shammy, she doesn't have a red t-shirt yet, but she's here bright and early.
Hi, guys.
Who else do we have? Who am I missing? I think that's it for board members here so far. And then you'll also see in the lobby, there are little stones. The theme of this is no stone unturned. And we really feel that we're hitting every angle that we could think of here in the symposium. And so you'll see these little stones. If you click on them, you'll earn points. And the people with the most points at the end, we have a little surprise for you. So throughout the event, you'll find these stones all over. Cher, anything else?
The only thing else I would say is on your screen at all times down at the bottom, you have links to the lobby, auditorium, different places. On the right, you have an attendee backpack. Kind of looks like a briefcase, but we're calling it a backpack. It is preloaded with several things, lots of links to resources, as well as some downloadable things. That is your own personal backpack. Anytime you are navigating through the site and you see something that you want to save, you just click the little backpack briefcase next to it and it'll pop right into yours. And you'll have access to that even after the conference closes for a short time. So just know that that is available to you and you can add things as we go. I think that's it.
Okay, Dr. Bacoli, are you ready to rock and roll early?
Well, good morning, everyone. I hope so. This is the one platform that we're not allowed to use out of like the top 10. So I have to say, I look at these buttons with a little bit of fear. And Roberta and Cher asked me to really talk about the basics of the basics in this first talk. And I'm looking at the list of participants, and the fear has accelerated as a few of the people on this are substantially more expert at some of the things I'm going to talk about than I am. So I'm switching from regular caffeine to decaf, and happy to go forward. And I am going to try to share my screen and avoid our hospital's security. That probably should not be recorded, should it? All right. Okay. And are people seeing my screen at this point?
Nope.
Not yet.
Okay.
Now we are.
Now, okay. And good. Slideshow presentation?
Yep.
Beautiful. All right. Well, welcome everyone. Thanks for inviting me to speak. This is the first of several of my talks for today, Alagille Syndrome 101, Introductions and Basics. I'm going to try to really keep this at the level of the kind of information that will help you to be conversant with your practitioners about Alagille syndrome. I think we have the ability to put questions in the chat, and I will probably talk for about half the time and then open it up, either open chat or open mic, to absolutely anything that anyone wants to talk about or ask about. My objectives are to provide really a basic introduction to the features and the factors that describe, define, and cause the Alagille syndrome, and to provide information and define many of the terms and the processes that are involved in these genetic disorders. And I'll leave time at the end for the geneticists to either augment or just plain correct me. So to really understand and talk about Alagille syndrome, you need to have some basic vocabulary and understanding around basic genetics. So the first thing is a gene is the basic coding unit for life or for function. And depending on who you read and what they consider to be genes, we have maybe 20 or 30,000 structural coding genes, but then we have a large number of other regulatory genes, and we probably have a lot of genetic material that we just don't yet understand what it does. But we're going to try to keep this, and thankfully for Alagille syndrome, we can keep this limited to the types of genes that are, I think, more easily understandable in what they do. They make something, and if the gene is not normal, they might not make it, or they might make something that doesn't work quite as well. So a gene mutation is any change or abnormality in a gene, and some of those can have a really life-altering effect on a person, and many of them really have no effect at all on a person. And we have inherited through the generations many gene changes or mutations that are part of the things that make us different one from another. And so for people who are interested in population genetics, different populations have had different genetic changes that have then been inherited and lead to some of the vast population differences that have occurred. So some mutations harmful, some mutations probably are part of the reason how we have evolved over the thousands or hundreds of thousands of years. But a genetic disease is when that mutation causes something that leads to a process that is bad for the host, for the person. And sometimes these are inherited, and sometimes these are new in the infant or in the person. A syndrome is a group of signs and symptoms that commonly occur together. And these, so Alagille is obviously a syndrome, but these are not always caused genetically. So we know that there are syndromes that occur. Some of the easiest ones to understand are syndromes that occur in a pregnant mother and happen in the fetus. So for instance, significant alcohol consumption or use of anticonvulsants, anti-seizure medications, or for people like in my generation, infections with things like congenital measles or rubella would cause a group of abnormalities in the child that were somewhat characteristic, and someone could look at someone and say, oh, you had congenital measles, or you had fetal alcohol based on those. But there are also a large number of syndromes that are genetic in their causes. And some of those we know, like Turner syndrome or Down syndrome, Marfan syndrome, other genetic disorders that have effects on many different parts of the body, maybe some labs, maybe some visual characteristics, maybe some developmental abnormalities. So a disease and a syndrome, we use them a little bit differently based on what we're defining. And Alagille syndrome is a syndrome. So it also is important to say that diseases or syndromes can be caused by more than one gene abnormality, or they can be caused by one gene abnormality. And so something like Down syndrome, there is an extra chromosome. It's a massive number of extra genes. And something like Alagille syndrome is caused by just one gene defect. Okay, so these variations and mutations, again, this variability of our genes are what make us different one from another. If we have 8 children, why those children are each different because they inherit different genes from their parents. There is a different impact of gene inheritance based on whether a gene is dominant, which means that one copy of an abnormal gene could cause the disease. There are a large number of recessive genes. Not all of those cause disease. So some people would say that blue-eyedness is recessive to brown. And if you have 2 blues, your eyes are blue. But if you have a blue and a brown, your eyes will be brown. Or if you have 2 browns, your eyes will be brown. Is that really consequential in life? It certainly is not a disease gene. But then other recessive genes are genes that cause things like sickle cell disease or cystic fibrosis, a huge number of other diseases where the one parent is typically a carrier, has 1 normal and 1 abnormal gene. The other parent is a carrier, 1 normal and 1 abnormal gene. And then on average, 1 in 4 children will get the abnormal from the father, the abnormal from the mother, and end up with the disease. So that's a recessive pattern, whereas in a dominant pattern where one parent only has 1 normal and 1 abnormal gene, if one child gets the normal gene, no disease, and if one child gets the abnormal gene, they're at risk for the disease. And then there are other kinds of genetics, and they progressively get more and more complicated as you go down the chain. But women have 2 X chromosomes. One of those chromosomes sometimes regulates itself in a complicated way, but men have an X and a Y. And so if a mother has an X that has a disease gene and an X that does not have a disease gene, and she gives the X with the disease gene to a son, that son does not have a second X chromosome to protect it because he has a Y. It's what makes him a boy, a male. And so there are a number of diseases, some of them very famous, like some forms of hemophilia that are on the X chromosome, and you can inherit those from your mother in a way that's a little bit different than the typical recessive or dominant genes. So a complicated area. There's not a test at the end on this, but it's important to know in understanding some of the questions around Alagille syndrome that this is really a very complex, but now very well understood group of inheritance patterns. So what about the changes or the mutations that we have in genes? So mutations can occur at any time, and the human body and most organisms want to repair or remove mutations if they can. So we have DNA repair processes that try to limit the number of mutations that continue or progress in us. But a mutation can occur in an egg or in a sperm because there's a very complicated sequence of steps that makes egg and sperm different from all the other cells in the body. But then mutations can also occur throughout life. And there are different patterns in that scenario. So one is a person could be a mosaic. They could have a mutation early on in life, and part of their cells that develop from that mutated cell have one set of chromosomal codes, commands, and the other has the original set of codes. And that has actually happened in Alagille syndrome, has been reported and studied. But for the rest of us, we have mutations in our genes all the time, and those mutations sometimes are inconsequential, but sometimes those are the kinds of changes that lead, for instance, to things like cancer. As we get older, there are clear mutations that result in leukemias, in colon cancer, breast cancer, other problems. And so these are important, and there's this balance between genes, which are very complicated, not exactly having clear, clean, perfect replication, and the body's desire to clear those abnormalities so that we continue with health. And then some things like mitochondria seem to have perhaps even more mutations and maybe are a part of aging. So this is the process, and somewhere in this sequence, in the current generation or prior generations, people who are interested in Alagille syndrome have had a change almost always in the JAGED1 gene, sometimes in Notch2, and that change, the timing of that change determines a few things, including particularly whether or not parents would have a risk of having a second child and a third child with Alagille syndrome or not. And there'll be several different talks that will spend more time talking about that. So as we said, some mutations are in high impact areas and they really matter. Some are in low impact areas and some are inconsequential, but we really believe that everyone has mutations, ones that we inherit, ones that accumulate over time. And so this is just a normal, abnormal part of our gene replication. So many of the diseases, as we said, are recessive inheritance, which means that you have to have two copies that come together. And in that kind of scenario, one from each parent, almost all of those diseases, the parent is not affected, and the parents are called asymptomatic carriers. There are more and more people now, and some religious groups, that screen parents to see whether they are carriers, even sometimes before they get married, so that they know what those risks are, even though the parents are totally fine. So many recessive genes and the diseases are fairly common, and we know a lot about them. And again, cystic fibrosis and sickle cell. And this mechanism has important implications for parents and families and for any type of genetic counseling if you go forward with that. But in general, the chance of having a child with a recessive disease, if you had one child with that disease, is 1 in 4. And the chance of having the next child after that is 1 in 4. And there's nothing about the statistics that says if you have 2 children with the disease, that your next one is any different than 1 in 4. Just like those 2 same people could have 8 children, none of them affected, even though they're both carriers. So each of these are independent events. And that's important when we talk about what are the risks of having another child with Alagille syndrome. So Alagille syndrome is different, and it's different from almost all of the liver diseases that we take care of, which is why scientifically it's very interesting to the scientists who are here for these 2 days, and a huge number of other scientists, because a dominant disorder behaves very differently, not just genetically, but in the implications of what that gene might be doing in the body. So dominant, again, means only one abnormal copy can cause disease. So it's inherited sometimes from one parent, but if the egg or the sperm gets a mutation in that gene, you only need one hit to make the disease. So it would be very unlikely for something like cystic fibrosis. If one parent is a carrier and the other parent is normal, it is possible that that egg or sperm might get a mutation in the cystic fibrosis gene and then have a child with CF. But the statistics on that are extraordinarily small. On the other hand, with Alagille syndrome, it's possible normal father, normal mother, and there's one mutation, and it happens to hit this very big and important gene, and that leads to Alagille syndrome in the infant, in the child, even though neither parent has a gene abnormality. So this is what we call a de novo, or a new mutation in a child. And for many dominant diseases, the child is the first person in the lineage that actually carries that mutation. Now, when I was younger, we could never tell. We would look at parents and we would try to give them the best advice that we could about what was their risk of having another child with Alagille syndrome. But we knew from the families who came to see us that there could be 2 children who have Alagille syndrome, and we're looking at the parents, and one of them must carry a gene mutation, but we just couldn't tell it clinically. So that then leads us to another part of the genetics, which is that sometimes you can carry an abnormal gene, but you don't have the manifestations of the disease that that gene causes, maybe some people would say should cause. So that becomes very complicated. And by being able to identify the gene, which we've now been able to do for more than 20 years and now is fairly easy to do, that has really helped us in understanding which adults carry an abnormal gene, and then to think about, might they have some other risks because of that gene, even though they seem apparently fine and have had a perfectly normal life up until the time when they had a child with Alagille syndrome. So why the name Alagille? And syndromes and diseases have a maddening naming nomenclature. And some of them are named for the feature or the process that the patients have. So in a sickle cell disease, the red blood cells sickle. And that makes a lot of sense. And what you see and what the disease is and why the disease occurs is fairly straightforward. More and more, geneticists are naming diseases according to a specific gene defect. So you'll have a number of letters or some other genetic identifier for a disease that doesn't necessarily fit anything about what that disease looks like to a clinician. But if you go back for a period of time, the vast majority of diseases were named after the person who described it, the person who claimed to describe it, even if maybe they didn't, or sometimes it's named after the patient who had the process. So in fact, Alagille syndrome is named after Daniel Alagille, who was really an incredibly bright French hepatologist, a liver doctor, who first described Alagille syndrome in the 1960s. And he called it,
todo mundo tem algum tipo de alteração genética.
Marcia?
Todo mundo na vida tem algum tipo de alteração genética.
All right.
É que não
Maybe
faz,
the moderator can put
90% delas
people
não
on
fazem
mute.
diferença. Tornam a gente com algum probleminha, ou alguma coisa diferente, sei lá, uma coisa fora do normal, alguma coisa assim, né? Fora do
Okay.
comum. É uma alteração genética.
Perfect. Thank you. All right. So Alagille was really incredible. And he described this and he called it syndromic paucity, which was sometimes translated into English syndromatic paucity, to mean that all patients back then were defined by a liver biopsy. And liver biopsy back then was a moderately high risk procedure. And he recognized that of all the patients who had too few bile ducts in their liver, some of them also had facial characteristics or other abnormalities, heart disease, heart murmur, that made this, took it from a disease, paucity, to a syndrome, multiple different manifestations associated with this paucity. And so it turned out that a significant percentage, actually probably a majority of the people who had paucity actually had these syndromic features. And for the next more than 25 years, there were multiple different names for this, and none of these names really fit. But we called this paucity of the intralobular bile ducts. We called this arteriohepatic dysplasia because the pulmonary arteries and the liver were abnormal, even though it wasn't really dysplasia. So if you want to go back and look at original papers, you can't really search Alagille syndrome because that's not what anyone called it for the longest time. And Alagille himself did not really like or want the syndrome to be named after him, I think for a very long time. But eventually the other names were just inadequate for describing this syndrome. And so we all agreed on Alagille syndrome, and he also, I think, fully agreed eventually to having his name attached. And so that's where the name Alagille syndrome came from. Now I'm going to go into a little bit of a more perhaps confusing area. So we said that in a recessive disease, someone can have a silent mutation and they are fine. And that is called a carrier status. But what do we actually call a person who has a JAG1 mutation, but who is fine? Do they have this syndrome? Well, Benita Kamath and Nancy Spinner, in a big extensive study a little more than 15 years ago, looked at families and clearly showed that some people carried the gene mutation, but they had nothing that you could identify that would make them a syndrome. So they didn't have signs, they didn't have manifestations, but they had a JAG1 gene abnormality, and they could have children who had regular Alagille syndrome. So were they carriers? Do they have the syndrome? And how do we use that as terminology? I think we've had a lot of fun talking about it, and I think maybe we'll have Dr. Hubbard, Dr. Anderson weigh in on that at the end. But at least in our group, it's one of the things where we've agreed to disagree on what we actually call that. It is a silent carrier, but whether they actually have the syndrome or not is a matter for debate. The important point, the last point here, is that a person who is totally unaffected, but who carries what seems like an unaffecting mutation, can have a child who has Alagille syndrome, and even very severe Alagille syndrome. All right, so some people would say, why so many liver doctors, and why are the consortia around Alagille syndrome mostly liver consortia? And the reason is that the original description of Alagille syndrome was to define one liver disease from another, and that the liver manifestations of Alagille syndrome are evident more in early infancy than some of the other abnormalities or features. Many of the patients have liver disease, although we know now they all seem to have liver disease when liver doctors were making the diagnosis. But now we know that the syndrome is much more extensive, and now our cardiology colleagues, as you'll hear from Dr. Feinstein and the cardiologists in the major cardiac centers in the country, make this diagnosis directly, because there are clearly patients who have Alagille syndrome manifestations in the heart, but they don't have abnormalities in the liver, or sometimes the liver disease is so minor in the beginning compared to the heart disease that it could be missed, it could be absent, but it could just be attributed to the cardiac disease itself, because there are many forms of congenital cardiac disease where the stress on the liver, being a little bit upstream to the heart, is really quite profound. So another question that commonly comes up is, why is biliary atresia so commonly confused with Alagille syndrome? And probably if you or your child was identified in infancy, particularly early in infancy, this is a major clinical challenge, and it's a little bit of a temporal emergency. And the reason is that biliary atresia and Alagille syndrome are both duct diseases. They're two of the most common early onset neonatal liver diseases. They both have a defect in excretion of bilirubin, and they have a number of laboratory abnormalities that are the same. So there are clearly times where you just can't tell them apart, or you can't tell them apart in the first phases of the workup, I should say. But the early diagnosis of biliary atresia can make a big difference in the outcome, because those babies need surgery to reconstruct, or more correctly, to replace absent bile ducts. And in Alagille syndrome, that same surgery certainly does not make the child better. And there's some feeling that it puts the liver and the drainage at a disadvantage. So the bottom line, these can legitimately, even in great centers with a lot of experience, be very hard to differentiate, and mistakes clearly have been made when you get the Monday morning quarterback a couple of weeks or months, or a genetic test way down, further, gives you the more correct answer. So what actually constitutes the syndrome of Alagille syndrome? So we've now become sophisticated in diseases and syndromes and genes, but what makes the syndrome Alagille? And the truth of the matter is, it's a very fascinating but unusual genetic disease, because there is no feature or any finding that is absolutely required to be present in Alagille syndrome. So bile duct paucity was the original launching point for this, a decrease in bile ducts. But in fact, some patients don't have that. Cholestasis, the decreased bile flow, the bilirubin excretion, the bile salts, the itching, the xanthomas. But again, a number of patients don't have that. Cardiac disease, or more properly, as Dr. Feinstein will show you, a murmur, which is sometimes outside of the heart, but in the vasculature, is a fairly common feature, but not always. There are characteristic facial features, but they're really very subtle and sometimes absent. There are eye findings. We anchor on posterior embryotoxin, but a large number of people don't have that. And a large number of people with other genetic diseases do have it. And then there are bone and spine findings, and again, usually not clinically consequential, also occur in some other things, but many patients do not have those, and kidney and vascular or blood vessel disease and other features. So this really seems to be a random assortment of abnormalities that may occur together or may occur alone. But I think for most of us, if you have even one feature and you have a jagged one gene defect, we say that you have Alagille syndrome, but there isn't a set of findings that sort of like breeds true. And also there are families where one person with the same gene will have a profound defect in the heart, another profound defect in the kidney, another profound defect in the liver, and another nothing at all going on, but carrying the same gene. And so this is one of the things that has perplexed and excited geneticists more and more as we get to understand some of the regulation that's involved in this Notch signaling pathway. So what causes the syndrome of Alagille? I think everyone knows, or will very soon know, it's abnormalities in the Notch signaling pathway. And this was a little bit of a surprise when it was recognized, but now looking back, it just all makes sense. And almost everyone has a mutation in the jagged one gene. But after looking extensively at a large group of patients, there were still some where the gene could not be identified. And some of those have been subsequently identified by better and better genetic techniques. But there was a mouse model that made Alagille syndrome, sort of, with a jagged gene defect and a Notch2 gene defect, And so it seemed to make sense to look in those patients who didn't have a JAG1 gene for Notch2 mutations. And in fact, Nancy Spinner's group found that mutations in Notch2 in a very small percentage of patients turn out to also cause something that looks like Alagille syndrome. But as is true in genetics, a whole other family of mutations in Notch2 in a different part of the gene cause something totally different. Although you could say facial characteristics, or bone, heart, but a totally different disease that would never be confused with Alagille syndrome. And now Nancy and Benita and others have looked at other mutations in Notch2, and it's also highly variable and still a little bit confusing, the implications of different mutations in different regions in Notch2, as well as different mutations in all of the other jagged-like ligands and notch-like receptors in this pathway, all have some manifestations that overlap, and a number of people will talk about those later in this two-day marathon. So I just want to start to close up by remarking on some of the landmarks in Alagille syndrome science and care. As Sharon, Roberta, and the board have pointed out, this is a long trail. I sort of feel like we're accelerating at this point because the science has become much better and the interest in Alagille syndrome has become much more focused. But if we go back 50, a little bit more than 50 years, that was the original description. And then really for the next at least 25 years, other clinicians and scientists refined the definition or expanded the number of clinical features of the syndrome so that there really are more than 50 different things that you might find in Alagille syndrome. And at that time, we were really stuck because we only had the ability to apply general liver medications to Alagille syndrome problems. So some of those medicines are gone and nobody remembers them. And some of them are the best in class medicines that we still use, but nobody ever did a big, great study back in those days of Alagille syndrome and medications. And no drug company, no pharmaceutical made medications specifically for Alagille syndrome. So we were really clinically stuck for a very long time in our ability to treat, other than a progressive increase in vitamins and our approach to malnutrition, which is very important. So then subsequently, there was the identification that in a small number of patients with Alagille syndrome, there were deletions on chromosome 20, and that those deletions seemed more than random. And so that pointed at that area of that chromosome being likely to be the cause for Alagille syndrome. But these were big deletions, and so we didn't really have an understanding about whether multiple genes together had to be deleted to make Alagille syndrome, or whether could it possibly be one gene, which was actually the answer. But then there was an explosion in the science and the search for the gene or genes that cause Alagille syndrome, particularly in the 90s. And then the identification that mutations in JAG1 could cause Alagille syndrome. And then progressively, mutations in that gene were found in more and more families, although many older patients would relate that sometimes you would be notified that a mutation was found, 6 months or even 6 years after you submitted a sample. Following the gene identification, it was possible to use those specific genetics to further define and to diagnose the syndrome. So this expanded what we understood about the syndrome, who had it, what the implications of that were, and that we could look at heart patients without liver or moya patients without liver and say, actually, you are related through your genetics to Alagille syndrome. So there was a lot of science that started up at that point. And with that, we went from research only testing for the gene to commercial labs that were willing and able to test families at a better and better price, with progressively more and more insurance companies being willing to pay for gene testing because of the important implications. And if you look now at how easy it is to do this and how cheap, it's hard to really recognize and see how unbelievably difficult this was to do, even 20 years ago. And even though the information and the answer was there. So the subsequent identification of mutations in Notch was interesting and really cast a bigger picture on the whole Notch signaling pathway rather than just JAGID1. And now we have comprehensive genetic testing with different techniques, whole gene sequencing, which we just couldn't have dreamed of, 20 years. We could dream of it, but we certainly couldn't do it 20 years ago. And now this is really very accurate. And so we can use it reliably to do things like counsel families on genetic risks and help them in their planning if they're interested in that type of thing. The other thing that has really moved the needle forward, there was CLIC, the Cholestatic Liver Consortium, that is now about 20 years old. And then people say, married the Biliary Atresia Research Consortium. So two groups of diseases very similar. They got married and they had children, which is the Childhood Liver Disease Research and Education Network. And the NIH has funded this, to their credit, at a sufficient level so that a large number of Alagille patients have been aggregated into one data platform. A number of different research things have been done, not just for Alagille, also for biliary atresia, alpha-1 antitrypsin, the FIC diseases, other similar disorders. But this has really, it's brought scientists together from across the US, from Canada, from across Europe, and allowed them to work synergistically, which is so different from a long time ago where everybody was secretive and competitive. And as a result, things didn't really move forward very much. And now, and you'll hear from Sharon Van Driel and from Benita Kamath tomorrow, a whole new strategy and structure with GALA, which is just really, so modern and effective and novel, and it's really great. You can't miss that talk. So one of the other really new and to me very exciting and satisfying things is that we are now in an era of the development of specific medications targeting Alagille syndrome problems. And so you'll hear a number of talks about that. But now we, for the first time, just in these last few years, have pharmaceutical interest. They know the word Alagille, they know the disease, they're motivated, and they have the tools that can really change lives. So this is really very exciting. If you're new to Alagille, you might think that people have been doing this forever. Not true. It's all very recent, but it's moving forward at a very fast rate. And then finally, the potential for gene modulation or gene therapy. Many people ask about this. For a number of recessive diseases, if you are missing one gene that works in one place, that is potentially replaceable. In Alagille syndrome, many of the things have happened developmentally, so that if you have tetralogy of Fallot, that has happened early on in pregnancy, and gene therapy to the heart could not possibly change that. On the other hand, and this is just theoretical at this point, but theoretical and plausible, in recessive genes, you have 2 abnormal genes in every cell in your body. But in Alagille syndrome, you have 1 normal jagged one in every cell in your body. So if you could figure out a way to increase that activity from 50% to 75% in one organ or another that was still developing, and the focus here might be the liver, if you could identify the disease early and change the amount of gene expression in the liver in an upward direction, could you make that liver grow bile ducts while it's still actively growing bile ducts in normal infants? And could you change lives? And then the big, big question, could you do this safely? It's one thing to do it in an animal model. Could you really do it in humans? So people have asked these questions. There are scientists who are trying to do things like this and re-regulate genes. We're all very excited about it. It is absolutely not here, not simple, has a lot of impediments, but there's at least a theory that this is a mode for gene therapy. I would say the other thing about gene therapy, which we have been really increasingly good at since the 80s, is when you do a liver transplant or a kidney transplant or a heart transplant or a heart-lung transplant, you are giving an organ that has normal genes and no abnormalities of jagged. So while it's a very different approach, a liver transplant, in a way, is a gene therapy approach to a new liver. So I think we take a little bit of joy and credit in that. It is certainly a therapy that increasingly works very well and can lead to excellent quality of life. And the safety after transplant is getting better and better as we develop better tools to control the immune system and a better understanding of tolerance. So there are big picture improvements, some now, some theoretical, and hopefully in the future. And I think we all want to try to support as much as we can all of the different advances that can occur, we would say should occur, must occur in the future. So this is that application of gene discovery, just so you have this to look at and think about. But we use the gene discovery for a number of things. We can now be precise and make an early diagnosis. There were a lot of times in the past where we weren't sure, and someone would be 5 or 6 years old before, the jury would come in and, on a 9-3 basis say, yes, this is Alagille syndrome. We're able to screen or to recommend screening families and relatives who are at risk, so that the youngest aunt of in a family who has an Alagille child could identify risk even out at that level. We can identify parents who are at risk of being this carrier status, whatever is the right word for that, even if they're fine. For families who want this, there are markedly improved options for family planning, either by counseling, which is risk stratification, or by direct techniques that have been done that sometimes involve even looking genetically at the fertilized egg before it's even implanted in a uterus. There are a broad number of things that are possible that are way outside the scope of this talk. So notch signaling pathway and jagged-1 alterations have become a major focus of laboratory research that has really elevated the importance of Alagille syndrome in the scientific world. And so that benefits everyone because there is so much work going on in the Notch pathway, and the Notch pathway really belongs to people who are interested in jagged 1. So we talked about these future applications, and this is a slide that sort of goes through that questioning strategy. And I think there'll be at least 2 people tomorrow who will talk much more elegantly and elaborately than I about what this is and what this would take, and what are the near-term and the long-term possibilities. So the future of Alagille syndrome patients and families depends really on so many things, but I think we have to say these multi-center, multinational consortia are just so extraordinary, and they are the platform that allows science and clinical care to move forward. And I hope that as many of you as is possible can be involved in children or gala. This helps you. It also helps the science. It's not available to everyone, but everyone, whether you're in one of those centers or not, benefits from the research and the support that has gone into developing these consortia. And then finally, and this is certainly why we are here literally and figuratively, is the incredible job that the Allergies Syndrome Alliance has done in terms of education, support, networking, advocacy, supporting research with money, supporting research with patients, giving us all focus, doing fundraising, grant writing, and of course, symposia, which are a great way to bring people together, bring high quality information, and get the support and the team building that we need to move things forward. So rah-rah for the board, rah-rah for Cher and Roberta, and for all of you for being interested in and being involved in this symposium and everything else that the Alliance does. And with that, I will, yeah, I think we should probably brag a little bit. There have been plenty of improvements, particularly in transplantation, in the cardiac care that Dr. Feinstein will talk about tomorrow, really incredible things. The interest by pharmaceuticals made a major difference, these long-term studies, and the Alagille Syndrome Alliance and families. There's a lot more to do, but people ask, what's the success? What's different than what we had? These are many of the things. And finally, prevention of Alagille syndrome. So for families, the first person in a family that is affected, it's always a surprise. Most of the time, no one has ever heard of Alagille syndrome, but there are options for family counseling once a family has been identified at risk. These are deeply personal. There are a broad spectrum of things that you can do. And if you go back to your center and ask for a genetic counselor and say, you know, what can you tell me? What can you do? They may have options that are really important for you. Gene replacement, we talked about it, and liver transplant is one great gene replacement that works. And now I think we have come to the end of this talk, and I will stop sharing and ask Stacy, Emma, Duke, anyone else to field some questions if anyone has anything that they would like to ask.
Dr. Piccoli, super quick before we start with questions, while everyone's listening, just want to make sure that everyone knows when this session ends, to go to the new session, you'll just X out and go back into the auditorium on the platform and click launch for the next session. So thank you so much, Dr. Piccoli.
share, is there anything in the chat that we should discuss?
Nothing in the chat, but if someone has a question, you can go ahead and just, since I can't see everyone at one time, if you just want to go ahead and shout out, we have about 20 minutes to take questions. Or if anyone else wants to add anything. I think, Emma, I think you just unmuted. There you are, in the sunshine.
Yeah. So I have a question. I really enjoyed your talk, and I thought it was a very helpful walkthrough of the history and the genetics. So thank you so much. What is your opinion about calling Alagille syndrome autosomal dominant, or you know, that there would be, that it's not recessive? When you talk about that there are individuals that have jagged 1 mutations with no disease presentation, what does that mean for, you know, calling it a dominant disorder?
Yeah. Well, there are many times where I am the outlier standing in the field alone, and I guess I've become comfortable with that over time. I feel, for simplicity, that everyone who has a jagged 1 mutation, where that mutation has caused disease either in their family or someone else's family, has Alagille syndrome, even if they have nothing wrong with them. Because in terms of what it would mean to people around them, family members, children, that's the simplest message. I acknowledge, and I suspect Nancy Spinner is not on right now, or she would jump on me. It's not exactly correct to say that, but I think you can be too perfect in terminology, and then you're not helping people understand what this means in their lives. So for me, it is important to say, and maybe this is the other half of your point, there are many mutations in the jagged 1 gene that mean absolutely nothing. And so there are some variants in that gene that are in the genetic database of normal people. And so the first thing that we do when we get a, and I'm not the person who does it, so I use the royal we. The first thing when we see a mutation that comes up on one of these genetic tests is it goes straight to the computer, and the computer says, oh, 8% of people from Southeast Asian ancestry have this variant. It means nothing. And then sometimes those people come to us because they've been diagnosed with Alagille syndrome. And I mean, I know one time from a distant place, they called, they set up, the parents were physicians. We looked at, we said, send us your mutation. They sent us a mutation. We said, that's not what you have. The reason it doesn't fit clinically is not what you have. A whole bunch of people, you know, have this variant probably in your family. So for a lot of genes, there are mutations, could be new, could be inherited, don't mean anything. But if you have a variant or a mutation, and somebody with that same code sequence ended up having Alagille syndrome, we believe you are at risk for having a child with the syndrome. And I, standing alone in the field, believe that you just kind of have the syndrome. You just don't have any manifestations of it. And I know that's wrong, but it seems right to me.
Yeah, I'm on the same page as you are. And I think the individuals who have like a broken version of jagged 1, but are disease-free, are extremely interesting. And I'm thinking that perhaps we as a community could study these individuals, because they could be like the genetic superheroes that were described a couple of years ago, who have mutations that should cause cystic fibrosis or should cause other usually dominant diseases, but they were protected because they had some other genetic difference. So, you know, I think it's valuable to study the sick people who have jagged 1 mutations and the healthy people who have jagged 1 mutations. So that was kind of what I wanted to lead to, that I'm on the same page as you, and I think it's super interesting. And now I'll stop asking questions because I feel like there were other questions coming up.
Okay.
Thank you.
Dr. Picoli,
Thank you.
we do have a question. Stephanie, hang on one second.
I can just talk if you want me to. I'm unmuted.
Okay, there's one question before yours, so hold on.
Oh, okay.
Dr. Picoli, this question is from Jamie. My third child has Alagille syndrome. My first two were tested 17 years ago and told they did not have it. With new mutations discovered since then, how should I advise these two as they begin family planning?
Yeah. So, 17 years ago, I was already feeling old, but it's the dark ages. So there is a better way to do this, and it may have been done or it may not have been done. So if the gene testing on child 3 was done, and if you know the mutation and they looked for that mutation in the other 2 children, and they don't have that mutation, then that is as close to 100% as you can have that they do not carry the risk, they do not have the syndrome, whatever Emma and I might call them, they don't have it. But if your child with Alagille syndrome, so we've seen this scenario where child number 3 was diagnosed with Alagille syndrome and died, and you don't have genetic material, and then you go back and screen your other 2 older children subsequently, and you don't find a mutation, 17 years ago, that was a little bit reliable, but not totally reliable, and they should be done again. So if you know the identity of the abnormality in your family, even 17 years ago, other people being tested, if they don't have this, they're fine. But if you don't know the identity of the person who is diagnosed, the genetic identity, you can test all these other people, and in 2021, you could get as high as 95% accurate, but 2021 minus 17, depending on where you did it, the accuracy could only be as high as 40%. If it was done in a research lab at that point in time, we were much better than that. But that was also in a time where we weren't even allowed to tell families the mutations we were identifying. It's kind of a little bit crazy, rules and regulations of research. So it's complicated, but if they knew in that child what the mutation was, number 3, then the other 2, 99% plus, should not have it.
Thank you. Stephanie, you can go.
So I was just kind of going back to what you guys were talking about a little bit. And this may just be kind of coming from my own personal experience of, even if you, like, at what point do you say someone doesn't show symptoms, or that they, maybe have the gene, but don't have any challenges from it? I know it's going to be discussed and stuff, but there's not a whole lot of information about adults with Alagille syndrome. So, even if you're like a healthy 30-year-old, you may have some challenges at 60 or whatever that, oh, this could be linked, towards Alagilles or whatever. So I feel like it gets a little bit muddy on that end too, of saying, you're an individual who has the JAGED1 gene, but you don't show any symptoms. At what point is that line kind of drawn? Because you may just not show them now, but it may pop up later on down the road too.
So that's a perfect intro to one part of the talk that we're going to do tonight. And I put together a number of slides that are based on our best clinical thoughts and guesses. You don't really have almost any adult physicians who know anything about Alagille syndrome. And although we concentrate pediatrics into big centers in countries, in states, whatever, you don't have that kind of expertise in adults. And we lose the pediatricians, we certainly lose control, we lose contact and whether the people have significant Alagille syndrome or they have this, nothing's wrong with me, but I carry the gene, we don't know. What we do know is that the manifestations can be independent. So you might have no liver and no heart, but you might have butterfly vertebrae. And I think one of the things, and Dr. Anderson is an expert in this, and also Benita Kamath, the question of, you might be fine in your heart and your liver and your kidneys, but what about your blood vessels? And so if
Or
you
reproduction.
or exactly, all these different things, moya, other things. So the these questions are open at this point, but it makes sense to understand the manifestations and do some degree of screening. You know, it would be really controversial to say that every adult with a jagged mutation, fine or not, should have a head MRA, an MR angiogram. Now, what's the hit rate for that? If you don't have headaches and you've been fine, nobody knows. Nobody knows. And when we tried to get the NIH to fund that study, they said, oh my God, that is so expensive and you don't have enough data and yada, yada. But I think the question, I'm 30, I'm 40, and I want to have a baseline of my brain and blood vessels in case anything happens. And maybe I do have a narrowing, or I do have a missing blood vessel, and at a time when I can do something about it. So that as a question, scanning the liver as a question, we don't know what is the incidence of problems, but we do know what areas problems could occur in. And then it becomes a little bit like 50-year-olds with colon cancer screening. Most people do it because they're told to do it. And the complication, colon cancer, is pretty common, but we don't know how common these things are in adults who carry a jagged mutation. But we have some ideas of things that we think maybe should be done. You might have an insurance company that says, no way, there's nothing to support you doing this, can't do it. And that would be a problem. So it's not like colon cancer screening where, you know, the insurance companies want you to do it and they pay for it all the time. So it's a tough field. We're evolving. We recently wrote a paper on liver cancer in adults with jagged mutations who were apparently healthy. And it's hard to say totally healthy because you're a point in time here and you're 40, 50, 60, 70 years old. Excuse me, who knows what they were like at age 30? We don't know because we can't go back there. But we know that there are those occurrences. We don't know the rate of the risks.
Dr. Piccoli, I think we have time for 2 more questions. There's one that has come in from Dr. Surendran, and then we'll have a question after that from Elizabeth. And I do believe that the session will cut off at 9:30. So Dr. Surendran, would you like to jump in and ask yours?
Sure. I was a little hesitant because I haven't had a haircut in a while. So, but anyway. So my question is sort of asking whether anyone's looked at the cellular level for the laws of heterozygosity. So coming from the sort of the cystic kidney disease field, you know, there's this idea that even ADPKD, the PKD1 gene is thought to be, you know, inherited in a dominant manner. But at the cellular level, if you look at why there are only a few cysts that occur, it so happens that there's this idea that the other copy is also mutated at the cellular level. I guess my question just simply is, has anyone looked to see whether that's a possibility in the case of Alagille syndrome, you know, whether it be the liver, yeah, is that known?
I think it's a great question. And as you state, you know, it's a process that can occur. And there's a disease called hereditary tyrosinemia, where there is, significant liver cell turnover, the liver barely turns over in life in most patients. And I think the hard part is if you developed two functional copies, it couldn't fix the damage that is now 10 or 20 years old. So it's different when ongoing damage occurs because of a process. In Alagille syndrome, the damage is done. I'm hoping Dr. Anderson is going to like come back on and bail me out here, or Stacy, but I theoretically could happen, but it won't help patients at all in my understanding of the damage done. Whereas in diseases where you need an enzyme, and an enzyme is suddenly, made, or a different kind of process,
Yeah, Dr.
yeah, you
Piccoli,
get
sorry.
little foci of goodness.
So
Yeah.
I think you might have misunderstood what I was asking.
Oh,
so
sorry.
I was sort of getting back at the idea of why some people with JAG1 mutations don't show a disease manifestation at all.
Ah,
Is it possible that at the cellular level, in order for the disease to manifest, the other copy also needs to be mutated? So it's sort of like only in your liver cells during development, let's say the other copy during replication also gets mutated. And is that the reason why you actually do end up having sort of this variable liver disease? And essentially, has anyone done sequencing of liver cells from people who are affected to see whether that happens?
I'm pretty sure the answer to the last part of the question is no. I see it. So I was being the optimist and having the correct gene, like in tyrosinemia, and you're having the correct gene go to the negative. I think it would be a hard thing to find. Could it happen? Absolutely, because you can have somatic mutations in anything, where I think you'd have to be doing single cell genetics. And I guess the question would be hard to apply that to a clinical importance in Alagille syndrome. Obviously, in other disorders, that 2 mutation hit or 1 mutation inherited and a second hit is a big part of things like cancer, among other things. Yeah, it's a good question. And I totally don't know the answer. And I suspect no one has done it. And I'm not sure anybody has enough money to do it, but yeah. Emma, help. All right, one more question.
Elizabeth, where'd you go?
Yeah. So my question was about the MRA. I'm in Canada. My child is young with JAG1. So I was wondering, at what age do we do the MRA, or is suggested, or is it only in adulthood that we should suggest it to the doctor? Or is it going to be kind of covered in a different chat if we don't have time to
Well, I
address
do
it?
think it's going to be covered in a different chat. And we don't have perfect information. And so each of us has our own clinical impression and advice. I like to have one MRA in a child between 5 and 10 years of age, sort of in the time when they can do that study without really getting general anesthesia, and it's a baseline. And sometimes we see they've already had a stroke, and sometimes we see that they're missing something. But then going forward, if you have head injuries or other things, or if you're considering moya, you have something to start with. So a good starting blueprint is valuable. And certainly if they're having headaches or dizziness or passing out, then you have indications for doing that, or seizures or post-op seizures. But even in asymptomatic people, we would like to have that done. We know when we find something, what really has not been well defined is if we did 500 kids, what would be the frequency of finding something at age 7 and at age 17? And if we had that data, which we didn't, then it would be a little easier. But for the most part, surprisingly, we're more likely to get a head MRA approved by insurance than we are to get vitamin D medicine approved. in the States.
Okay. Thank you all so much. There's been a few additional questions. Dr. Piccoli, I've copied those and I'll follow up with you on those throughout the next day. Again, thank you all so much for being in here. If you are attending the next session, one second, Emma, if you're attending the next session, just be sure that you log out of this, go back to the auditorium and click launch on the next session. If you want to take a look around in that lobby, you can go to the networking lounges, chat with one another, and go to the expo hall and see some booths. Emma, one last thing before it cuts us off.
I was just clapping. Fantastic.
Oh, oh, thought you were raising your hand. Yay, clapping. Okay. All right. Thank you all so much.
Thanks, everybody. Good luck.
All right. See you soon.